Okay, it's already 9:07.
I think we will only keep a time, ma'am. I'll
Okay.
keep the time.
You will keep the time. Okay, then fine. So shall we start?
The first presenter.
Please start, ma'am.
Yeah, FP909.
Hello, ma'am. I'm FP909 Deepika, ma'am.
Yeah, please keep your video on.
Yes, ma'am.
Yeah,
Good morning,
you can
ma'am.
start.
Shall I start my presentation?
Yes.
ma'am. Good morning, everyone. I'm Dr. Deepika, presenting a paper on barriers responsible for delayed presentation of patients with bilateral mature cataract. Cataract is responsible for 50 to 80% of bilateral blindness in India and around 40% globally. In spite of having national program for cataract, there has been delayed presentation of patients to hospital. There is scarcity of local data about the profile of late presenters to the cataract and its associated factors. Hence, the aim of our study is to evaluate the reasons for delayed presentation in patients with bilateral mature cataract. Materials and methods. We conducted the study with a study population of around 62 patients attending the OPD basis of Department of Ophthalmology. The duration ranged from August 2019 to March 2021. It was a prospective observational study. All adult patients with bilateral mature cataract were included. Patients with significant mental illness and communication difficulties were excluded from the study. Methodology. The study population consisted of 62 people, out of which 34 were females and 28 were males. Patients were subjected to detailed history taking, including socio-demographic details like locality, occupation for about 15 to 20 minutes, and then thorough ocular examination was conducted in the form of vision, slit lamp, and tonometry. Descriptive data analysis was conducted and reported in numbers and percentage. The results were tabulated as follows. We can see that age was arbitrarily divided into three categories: 20 to 40, 40 to 60, and more than 60. Around 77.7% of the people belong to the age group of more than 60. This indicates that elderly age group was one of the significant barrier for delayed presentation of patients to the hospital. And coming to the gender profile, we can see that there is a higher incidence of cataract in female population compared to the male population in our study, around 1.2 times higher incidence in female compared to male ratio. And coming to the residents, we can see that around 80.6% of the people were residing in rural area, because accessibility comes forth as a major barrier for the people residing in the rural area. And coming to the education, it was categorized into four types. And we can see that 93.5% of the people in our study group were illiterate, and only 3.2% of the people managed up to primary school. This is one of the significant barrier too. This indicates that people did not have knowledge about the cataract surgery, and they had fear relating the surgery and even regarding the outcome of surgery. Most of them had the attitude that they have to wait until the cataract is ripe enough to undergo surgery, which was followed from earlier days. And coming to the systemic elements associated with it, hypertension and diabetes were the most common comorbidities seen in patients presenting in our study, and hypertension being more common than diabetes, accounting for around 62.9%. Coming to the occupation, we can see that around 62.9% of the people were unemployed in our group, because most of them were elderly and were dependent on someone. And the next is farmer or labor class, accounting for 22.5%. This was a group of people who expressed financial concern because they thought there will be loss of daily wage of labor wages if they visited hospital, and most of the time they're the earning members of the family. And coming, when we calculated the time period from the onset of bilateral defective vision to the presentation, we found that around 66% of the people took around 3 to 6 months to present to the hospital, and more than 21% of the people took more than 6 months to present to the hospital. So when we started evaluating the reasons for delayed presentation, we found out that COVID pandemic was a major cause for the delayed presentation in our patients, measuring up to 67.7%, wherein most of the people delayed surgery because of fear of pandemic, and most of them had transportation difficulties because of the lockdown. And hospitals were offering only emergency care because dealing with the COVID pandemic was a major priority there. Lack of awareness was the second most common cause, measuring up to 14.5%, as most of them were illiterate. Old age with comorbidities measures up to 6.45%, because at this age group, they need someone else to accompany them with. Others being the economic issue and insensitivity to female health, because 5 of our patients expressed financial constraints that there could be out-of-pocket expenses during or after surgery. In our study, most of them belong to the age group of over 60 years and were females. And in the study conducted by Nirmalan, similar observation was seen, like lower number of cataract was seen in male population, which can be attributed to factors like lower nutritional status, cultural insensitivity to a female's health needs, as most of them are confined to households. Our study revealed that most common cause for late presentation was COVID pandemic, and most of them delayed surgery in fear of pandemic and transportation facilities due to lockdown. Second most common cause was lack of awareness, as most of them were illiterate and were from rural area. So in the study conducted by Lipi Chakraborty, revealed that lack of awareness, old age, systemic ailments were the factors responsible for delayed presentation to the hospital. So concluding, educational efforts related to cataract should aim to reach the rural population, and most issues can be addressed through repeated counseling sessions by healthcare providers. There is a need to formation of strategies to improve accessibility in the form of transportation facilities or conducting camps in the areas which are very inaccessible or located very far away from the hospital, and awareness in patients seeking delayed medical attention. COVID-related safety precautions should be taken in hospital preoperatively and intraoperatively, which may also improve the uptake of patient. Thank you.
Yes, Dr. Deepika,
Yes, ma'am.
a good collection of data. What was the period of your study?
Ma'am, 1 year, 7 months, ma'am.
When did it start?
I started from August 2019, ma'am.
When did COVID start?
February 2020. We didn't have that much data collection from March, April up to
No. See, from your study period is from March 2019, huh?
No, ma'am. From August 2019
Okay,
to March.
August 2019 to March till the COVID lockdown happened. So
Yes, ma'am.
it was almost like 7 months you had.
Our study, we had 1 year and 7 months from
Correct, agree.
August. Yes,
The
ma'am.
pre-COVID lockdown, how many patients you collected?
Pre-COVID lockdown, we had around 23 patients, ma'am.
Okay, the total number was?
62 patients, ma'am.
So nearly 1/3 were present even before the lockdown.
Yes, ma'am.
So why do you put the blame entirely on the COVID?
When I started collecting data and when I asked about the people, they said that they didn't turn up for the surgery because of the COVID pandemic. As
I agreed, but what about those people who were collected
ma'am.
before the COVID?
In that time, most of them belong to the old age kids, ma'am, and most of them did not have idea about the cataract. And 2 of the patients told me that they didn't have their son or any other siblings to take care of them, who didn't even take them to the hospital for further treatment.
Okay, so these patients who were represented to your hospital or at the campsite?
No, ma'am, to the hospital, our hospital, ma'am.
Our hospital. Your
Yes,
hospital is based in a rural area or urban area?
Urban area, ma'am.
Urban area.
Yes, ma'am.
So this patient came from the rural area to the hospital?
Yes, ma'am. Nearby rural areas to our hospital. Yes, our hospital caters to both the urban and rural areas, ma'am.
So which district your institution is?
Mysore, ma'am. Mysore. Yes, ma'am.
Yeah. So, I mean, that's not from my side.
Hello, ma'am.
Yeah,
hello.
Other judges.
Deepika.
Yes, ma'am.
It's a good study, but when you're telling about the data, demographic data, you said you actually said some of your assumptions there, right? When you were telling about the literacy and the education status as well as employment.
Yes, ma'am. And because when I saw about the employment, because 60% were unemployed because they were old age people, no, ma'am. They were not earning. So there was no earning. And second was labor group of people. When I asked about them why you didn't come up for surgery, they told that there'll be loss of daily wage. Per day, they'll be earning like some 150, 200 rupees, ma'am. If they come for 1 day, they need for cataract evaluation if they come to our hospital. So it's like loss of that wage will be there for that particular day. And sometimes they are the earning member of the family. They have to look over the family. So that was also for them, and additional transport charges could be there because if they travel from rural to urban area, additional transport bus charges are also there. So these were all the financial constraints that people faced during that time when I interviewed them.
Okay.
So with the mature cataract, they were earning?
Ma'am, and like before that, my study is that why there is a delay. It's not like both of bilateral defective vision did not start simultaneously, no ma'am. Initially one eye was the defective and then the other eyes. So when they came to hospital, when both the eye were defective, until that they were earning.
Shall we go to the next candidate?
I think if there are no more questions, the next candidate can present.
Yeah.
Yes,
Free
ma'am.
paper 1455.
Yes, ma'am.
Please keep your video on. Shall we go to the next candidate? You sort out your problem. Dr. Vidya?
Yeah, ma'am. We can go to the next one.
Yeah. So the next candidate, you please log out and sort it out.
Hello.
Dr. Divyashri, you please close. We'll come back to you. Yeah, we go to the next free paper session, 1101. Vidyashri, you please close your presentation.
Yes, ma'am. I've double clicked, but only it's not appearing for you. It's giving me.
Hello.
I you stop sharing your slide, Divyashri. Let
Hello.
1101 free paper, that is Sampada.
Yeah, ma'am. Can you hear me, ma'am?
Yeah,
We can hear you, but video on and we can't see the
Okay.
slide.
Okay, ma'am. Can you see the screen, ma'am?
Yes.
Okay. I'll be presenting a paper on the prevalence of myopia among school children during the COVID-19 pandemic due to excessive screen time. Introduction. On December 30th, 2019, Dr. Willig Lee alerted the world about the possibility of a severe acute respiratory syndrome virus outbreak in Wuhan, China. Several months later, the WHO, one minute, ma'am. WHO declared COVID-19 a pandemic outbreak. Educational institutions in the country had been closed since March 2020 to halt the spread of the novel coronavirus disease. However, there is uncertainty as to when these schools would reopen. Since there was no immediate solution to the spread of the COVID pandemic, the closure of the schools will have a large effect on the learning of the children. The outbreak has changed the traditional teaching method of using blackboards to digital device assisted online classes. Spending long hours in front of these devices can lead to many ocular problems in children. Digital eye strain is the most common eye problem associated with prolonged digital use, characterized by symptoms such as dry eyes, itching, foreign body sensation, watering, blurring of vision, and headaches. Although the ocular complications of digital device use have been extensively studied in adolescents and young adults, only a few studies have addressed digital eye strain in children. Ocular symptoms and digital eye strain related to the excessive use of digital devices due to the increased duration of online classes in this COVID era have been discussed extensively in the media but have not been properly studied and reported in the literature. Purpose of my study is to know the impact of increased digital device usage arising from lockdown measures instituted during COVID-19 pandemic on children's vision and lifestyle changes. Methodology. This is a community-based study in which 250 school children aged 6 to 16 years from randomly selected schools were screened for myopia who attended online classes during the COVID-19 pandemic. Duration of the study is 3 months, that is August to October 2021. Number of children from each school is selected based on sample proportionate to size. 16 eye strain related symptoms were asked to the students, including burning sensation, itching in the eyes, foreign body sensation, watering, excessive blinking, redness, eye pain, heaviness in the eyelids, dryness, blurring of vision, double vision, difficulty in near vision, intolerance to light, colored halos, worsening of vision, and headache. A brief history of hours of screen time followed by visual acuity testing, retinoscopic examination, best corrected visual acuity followed by anterior segment and fundus examination was done. This is my sample size calculation. My sample size was estimated as 237. I approximated as 250. Study design is a community-based study. The children of their children or their parents were asked to indicate the average time in hours per day spent on each of the following activities: computer or iPad use, smartphone use, online classes during the COVID-19 era, as well as the total duration of digital device use before and during the COVID era. Digital eye strain symptoms and their severity and frequency were recorded. Ocular examination, visual acuity was measured using a Snellen chart. Children with less than 6x vision were asked to come to the hospital for further ophthalmic examination and for subjective correction. Cycloplegic refraction was performed, and cycloplegic regimen consisted of at least 2 cycles of eye drops of 1% cyclopentolate and 1% tropicamide. A third cycle was administered 30 minutes after the second cycle to ensure that the pupils were well dilated. This is the incidence of digital eye strain. A percentage of children with different grades of digital eye strain. Mild, no strain were 45 children, and with mild eye strain was 30, moderate was 50, and severe was 15, and moderate was 15. This is the demographic details. Mean age in years is almost, it was 13 to 14 years, 13 to 16 years. Male were 150 and females were 100. I did a screening from 3rd standard to 10th standard, and third to 5th standard students were 75, 6th to 9th were 85, 9 to 10 standard was 90. Duration of digital device usage pre-COVID era was less than 5 hours was 13 classes, and more than 5 hours was 4 classes. And during the COVID era, it was increased. So less than 5 hours was 137, and more than 5 hours was 80. Total classes attended online was 209. Duration of online classes, less than 1 hour was almost 13, 1 to 2 hours was 88, and more than 2 hours was 108. Age group and in years, and myopia prevalence, and specific equivalent error was seen. In 6 to 9 age group, students were 70. It was myopia prevalence was 8.48 percentage, and spherical equivalent error was 0.04. 10 to 13 years was 18.03, and spherical equivalent error was 0.33. 13 to 18 years, it was 29%. Almost the spherical equivalent was more in 13 to 18 years age, that is 0.62. The total number of students I had covered was 250. Myopia prevalence almost was 26.6, and spherical equivalent area was 0.32. Discussion. Due to the spreading of the COVID-19 pandemic worldwide, many states or central governments have decided to close schools in order to maintain social distancing as means of halting the transmission of this deadly virus. There are growing concerns about a potential myopia boom during the current pandemic as a result of changes in lifestyle and behavior due to school closures and restrictions on social activities. Digital learning has become a daily necessity during this COVID-19 pandemic, leading to a marked increase in digital device use among children of school-going age. In our study, 96.3% of the children were attending online classes for e-learning. A European study reported that 68% of children regularly used computers and 54% undertook online classes. In our study, 36.9% of children spent more than 5 hours on digital devices, which is similar to the pattern of a study conducted by Badri et al., who reported that the average time spent on social media by students was 5.2 hours per day. The increased prevalence of digital eye strain in our study is probably due to the increased visual demand on digital device use because of the online classes in this COVID era. Duration in front of a screen of more than 5 hours was found to be a significant risk factor for higher digital eye strain scores in our study, which is well-known factor for asthenopia among digital device users. A study reported that the prevalence of digital eye strain was significantly higher in individuals who spent more than 4 hours per day on digital devices. Children should be encouraged to blink when reading text on screens, avoid keeping the device close to the eyes, monitor screen, and include a healthy diet rich in carotenoids and green leafy vegetables. Adequate sleep is necessary. Regular eye checkups are strongly recommended. Conclusions.
Your time is up.
Last slide, ma'am.
Yes.
Our study highlights the higher prevalence of digital eye strain among the children in the present scenario of the COVID-19 pandemic and the effect of the e-learning teaching model on children's ocular health. Our findings highlight an important child ocular health issue in this era and make the parents, teachers, and eye care providers to the considerate about evidence-based measures to avoid digital eye strain in children. Our results serve to warn eye care professionals and also policy makers, educators, and parents that collective efforts are needed to prevent childhood myopia, a potential public health crisis as a result of COVID-19. Thank you.
Yes, Dr. Sampada.
Yeah, ma'am.
The less than class 5 opened recently, isn't it?
Yeah, ma'am.
So, but your study period is from August.
Yeah, ma'am. Here the classes were started from August, ma'am.
Less than class 5 also.
Yeah, ma'am. Few schools were obtained. Few schools didn't have less than 5, ma'am. So after, like, during the October period, I covered those classes also.
Okay, I thought the less than class 5 was opened here and all only recently in November. In December.
Here it was started already, ma'am.
Which place?
Bagalkot, ma'am.
Bagalkot.
Yeah.
Your title says prevalence of myopia.
Yeah, ma'am.
But your conclusion is you talked everything about digital eye strain.
Yeah, ma'am.
So why did you title it like that?
Actually, my whole thing was myopia, ma'am. But most of the like students didn't come for the hospital, ma'am.
So you should have concentrated more on myopia, isn't it?
Yeah, ma'am. Actually, I should have.
Everything is about digital eye strain.
Yeah, ma'am.
So one who is missing was how many kids were using glasses at the time of presentation?
Yeah,
the children you screened, how many were already having glasses, and that glass and the present, the new, whatever you checked, was there any difference? That data is missing.
Yeah, ma'am. I actually couldn't do it, ma'am. I actually took the glasses. I had done screening, no, ma'am. I couldn't take the number. What was the glass of that, ma'am?
Okay, fine. But at least you should have the number, no? How many were already using glasses?
Yeah, ma'am.
Already having the refractive error.
Yes, ma'am. I couldn't do it.
Yeah, so that's all of my
Sampada, one more, Dr. Smita here.
Yes.
So one more query is, what are the other bias factors, confounding things which you would like to add?
Even the not only because of the online classes, children at this in this generation, they are even using the screen mode.
Right. How did you negate that?
Yeah, video games also they are having.
No, how did you? Yeah, right. You're right. But how did you negate that factor?
Actually, I was doing only the school screening, ma'am. Because of that, I couldn't take that information, ma'am. School children, they are not so knowledgeable.
Don't you think that's a big factor, biasing factor?
Actually, ma'am,
which will totally.
Yeah, actually, ma'am. But I couldn't. Most of the schools didn't have the parents, ma'am.
So shortcomings should be mentioned of the study. And your name is Sampada, right?
Yeah, ma'am.
The study of digital eye strain. I have got it in front of Dr. Ziba. I would like to ask other evaluators, is it the same with you?
No.
Please enlighten.
Dr. Smita, Preeti here. It's the community sessions which is going on. After the 5 papers of community, pediatric will start in the same session.
Okay, the study of digital eye strain among children in online.
That is pediatric session. That is pediatric
session. She is
session.
presented same, no? It is Sampada.
It is
I think she has another paper in prevalence of ocular trauma in tertiary care hospital,
same
right?
paper you have?
Yeah, different paper, ma'am. Pediatric ocular trauma.
Okay, okay. Sorry.
Yeah, okay.
So, I mean, our screen, it is Dr. Sampada only.
Okay.
One more question, Sampada. What was the working definition of myopia? Have you put that in your methodology?
It was actually myopia prevalence. Definition.
How was the study done in the community? where was school screening allowed during that period?
Yeah, ma'am. Actually, our college has a school itself. So we had gone our college school also, ma'am. And there are here the community medicine of the communities medicine people are very cooperative in this enough, ma'am. They gave me permission for the school screening, ma'am. They took the permission from them and got it for me, ma'am.
Okay. Yeah, that's it.
Okay. Thank you.
So we go to free paper 998. Dr. Shalaka, are you ready?
Yes, ma'am.
Yeah, please. Sampada, please stop sharing.
Good morning, everyone. Myself, Dr. Shalaka from JJMMC Medical College. Here's a study on prevalence of refractive error in school-going children in district of Davangere. Introduction. Refractive error is a major contributor to the visual impairment, which is a significant cause of morbidity in children worldwide. Since children do not usually complain of visual difficulties, early detection and prompt treatment of eye disease is important to prevent vision problems and eye morbidities, which could affect the learning, ability, and personality and adjustment in school. The right to sight The Right to Sight Vision 2020 had special emphasis on childhood visual impairments, blindness, and uncorrected refractive errors, which is a global initiative launched by Coalition of Non-Government Organizations and WHO to eliminate avoidable visual impairment on a global scale. Refractive error study in children surveys were designed to assess the age and sex-specific prevalence of refractive error and related visual impairment in children of different ethnic groups and cultural settings using consistent definitions and methods. To cater the rising prevalence issue, various school eye screening programs have been evolved in Indian context, majority of them under the initiative of District Blindness Control Society to yield the highest effect from timely referral and correction. District of Davangere has a population of 4,86,000 according to 2017 census. Davangere consists of a socio-economically heterogeneous population who are residing in low-income housing typical of urban resettlement colonies, in the middle and upper middle income, in urban slums within the area, and in several remaining in original villages comprising lower middle and middle economic strata. Therefore, there is a need to know the prevalence of refractive error in school-going children in order to take appropriate actions and make our future generation bright and beautiful. Objectives of our study were to determine the prevalence, number of students diagnosed with refractive error during school eye screening programs in school-going children in the age group between 9 to 15 years, type of refractive error, and management. Materials and methods. The data was collected from the refractionist working in the district hospital Davangere, who screened children of both rural and urban schools of Davangere. It was a retrospective study with 5,437 students from 37 schools were screened for refractive error. The duration of study was from March 2018 to March 2020. Students of both sex attending school between age group of 9 to 15 were screened for refractive error. School dropouts or students who were absent during the school time or any other protein energy malnutrition, such students were excluded from the study. The study was undertaken depending on the data available from the refractionist, optometrist, school teachers, and social workers in the Taluk and district of Davangere. Approval from the institute was taken to retrieve the documents of the patients who were screened. Student demographics such as name, age, sex, school name were noted. Details of comprehensive examination like refractive error, spherical and cylindrical error and their management were noted. On the basis of records, they were categorized. Results, out of the 5,437 students who were screened, 755 students had refractive error, that is about 13.88% of prevalence, out of which 487 girls and 268 boys were there, that is about 15% and 15.13% and 12.07% respectively. Coming to the type of refractive error, 550 students had only spherical error, that is about 72.8%, and with spherical and cylindrical error was seen in 27.2%. Coming to the categorization of that, the simple myopia, that is a low degree of 0 to -2, were seen in 391 students, that is about 71.1% of the students, and -2 to -4 degree of refractive error was seen in 110 students, that is about 20%. The rest were distributed in as that is about 5.1% greater than -4, and about 2.4% and 0.7 had hypermetropic error. After giving correction, about 740 students improved to 6.6, that is about 98% of the students who have improved to 6.6 vision, 0.5% to 6.9, 0.1% to 6.12, and 0.5, 0.7, and 0.1% in 6.18, 6.24, and counter figure 3 meters. Depending on the type of refractive error, about 530 students had simple myopia, that is about 70.2%. With the rule, astigmatism was seen in 14.7% of the students. Against the rule, astigmatism was seen in 12.4%. Amblyopia was seen in 1 student, compound myopia in 3 students, and pathological myopia in 16 students. Coming to discussion, for the past few years, many Indian villages have become developed with access of basic amenities just like other urban counterparts. India is also witnessing a digital revolution starting from past decade with increasing number of televisions, mobiles, laptops, and computers. Internet usage has increased dramatically owing to reduced data tariff, low-cost smartphones, and improved telecom connectivity in Indian villages. This might have resulted in decreased outdoor activities, increased near work, and computer-related visual stress and fatigue. Changing schooling pattern to high-pressure education system can also be another contributory factor. While direct causal relationship may be difficult to prove, but the rapidly changing environment, especially the ongoing urbanization of the rural environment in India, could be implicated as a potential factor for rising myopic prevalence. Systemic review by Sheila Devi et al. Showed very low prevalence of myopia in rural settings as compared to urban settings. That is, in rural about 3.5% and about 10.8% in the urban areas. Holden et al. Has estimated the prevalence of myopia in South Asian region, including India, to be around 20% in 2010, 38% in 2030, and 53% in 2050. The limitations of our study were only presentees were included in the study population, only school-going children were included. A significant proportion of children in rural India do not go to schools. Hence, a more complete assessment of visual impairment in children would be possible with population-based studies, not restricted only to school-going children. Coming to conclusion, health education regarding refractive error and spectacle usage should be encouraged. School teachers to be assigned monthly screening and identifying such problems and referring the child to the nearest government hospital. Regular screening programs can reduce ocular mobility in school-going children. Myopic control programs can require consistent efforts to increase the awareness about risk factors, encourage lifestyle modification, changes in the school curriculum, education policy of the country. Therefore, there is a need to stimulate the initiation of various preventive and corrective measures of myopia control, resource planning, infrastructure augmentation, especially targeting the school-going children. Thank you.
Dr. Shalaka, you mentioned it is a retrospective study.
Yes, ma'am.
Why? How was it done?
To our college, a government hospital is also attached, ma'am. We have been posted in the government hospital also. So they take us to the school-going program whenever the optometrists go there, ma'am. So I couldn't get all the data. So whatever the data was available with them, I took in the, they have a note of every school they go, they assess, and every correction they give is there with them, ma'am. The records are available. So I took the record from them and then tabulated and did the tables, ma'am.
So the data may not reflect the real issue.
Yes, ma'am.
That's a big drawback.
Yes, ma'am.
And again, if you look at your conclusion, to say myopia is the issue, what are the number of myopic children you found in your study? It's not
almost, yes, almost 500 students out of the 700 students, around 600 students.
Yeah, but the significant myopia was only 25%, isn't it? More than 2.
Yes, ma'am. More than 2% was seen in 20% of the population.
Correct. Yeah. So that's all from my side.
How did you, Dr. Shalaka,
Yes, ma'am. Yes,
you, how was the glasses given to these patients, to these children without cycloplegic refraction? Was it given at the school itself?
Yes, ma'am. Few students it was given, and few students were referred to the government hospital where we used to give correction for them, ma'am. We did refraction in the hospital and we used to give that, but the data of all students I took from the register which was maintained, not from the students itself. So both the students who were given correction at schools and those who came to the hospital, we have a register maintained, ma'am. So collected the data from that register.
How many were, you said only very less number of amblyopia, right? Only one case you have said.
Yes, ma'am.
There was no anisometropia in your study?
They were there, ma'am. The problem was while tabulating, we've considered only one eye to tabulate, ma'am, because both eye we have not considered. So few are missed in that, ma'am. So that is also a drawback because we couldn't consider both eye while evaluating. Anisometropics were also there.
Okay. Again, working definition is not mentioned in your methodology for the refractive errors.
Yes, ma'am.
Yeah, that's it from my side.
Okay.
Okay, if Dr. Divyashri is ready with your preparation.
Yes,
so can she present, Dr. Vidya?
Yes,
yes, ma'am.
Okay.
Ma'am, I think.
Yes, we go to the next candidate. Paper 889. Are you ready?
Yes, ma'am. Can I present now?
Yeah, please. Divyashri, please stop. Dr. Soumya can start.
Yes, ma'am. Is it visible, ma'am?
Yes.
Good morning, everyone. Myself, Dr. Soumya. Today, I'll be speaking about the topic, an insight into reasons for increased proportion of hypermature cataracts and its complications due to COVID-19. Introduction. Cataract still forms one of the major causes of total blindness as per I'm sorry.
Yeah, put it in PowerPoint show.
Yes, ma'am. I'll start now.
Yeah.
Cataract still forms one of the major causes of total blindness, that is 62.6%. As per NPCB, incidence of cataract is 0.4 to 0.5%. Thus, the number of new cataract cases to be operated every year comes to 61.5 lakhs. Hypermature cataract is defined as a stage of senile cataract which develops due to liquefaction and absorption of cortical matter, leaving behind a small shrunken nucleus with an overlying fragile capsule that may have undergone calcification or fibrosis. All the cataracts should be operated before they reach the stage of hypermaturity. The complications associated with hypermature cataract include lens-induced uveitis, phacolytic glaucoma, and rarely spontaneous dislocation of nucleus. Chances of intra- and post-operative complications are also high in cases of hypermature cataracts. Associated phacolytic glaucoma, which is a potentially preventable condition, continues to be the cause of irreversible visual loss in India, especially among the patients from rural areas. Intraoperative complications can arise due to various reasons, like difficulty in doing continuous curvilinear capsulorhexis, zonal adhesion during nucleus emulsification, or even during nucleus removal due to weak zonules. Post-operative complications such as dry keratopathy, raised intraocular pressure, and prolonged inflammation are more commonly seen in individuals with hypermature cataract undergoing cataract surgery. Patients with phacolytic glaucoma might also have a poor visual recovery post-operatively due to optic disc damage. Reasons for late presentation according to previous studies are lack of caretakers, poverty, poor awareness, poor health education, acceptance of poor vision as a part of aging, unwillingness for surgery, and coexisting systemic diseases. Due to these factors, hypermature cataract continues to form a significant percentage of overall cataract burden. In early 2020, WHO declared the outbreak of COVID-19 caused by the new variant of coronavirus 2019 novel coronavirus as a global pandemic, following which the government of India ordered a nationwide lockdown for 21 days, further extended to a total of over 50 days, thus limiting the movement of people as a preventive measure. The COVID-19 pandemic halted non-emergency services across India. Elective cataract surgery postponed during the pandemic invariably led to a longer wait and possible anxiety among patients. Patients' apprehension about having cataract surgery during the easing of COVID-19 lockdown should not be ignored. Despite significant changes made in the plethora of ophthalmology services during this time, there is a scarcity of research centered on the statistical analysis of increase in the burden of hypermature cataract cases. The main objective of this study was to assess the increase in the proportion of hypermature cataract and its associated complications during the era of COVID-19 pandemic, and also to evaluate the reasons for delayed presentation with the help of a standard questionnaire. The study was an observational study, also an interview based. It was conducted over a period of 1 year from August 2020, post the ease of lockdown, to August 2021. It included 398 cases of hypermature cataract presenting at our tertiary center. Inclusion criteria: all patients with features of hypermature cataract and its complications like subluxation and phacolytic glaucoma presenting late during the study period were included after obtaining a written and informed consent from each patient in their own vernacular. Exclusion criteria: patients with other comorbid conditions in the eye like pre-existing glaucoma, those diagnosed as phacomorphic glaucoma, and pseudoexfoliation or trauma leading to subluxation were excluded from our study. Presence of good vision in the other eye or pseudophakia leading to good vision in the other eye was a notable cause of delayed presentation. Thus, such patients were also excluded. A detailed ophthalmic examination was done of both the eye. The lens status of the other eye was noted. The patients were interviewed on one-on-one basis on a face-validated questionnaire designed for the history taking, followed by following COVID-19 safety precautions. All patients were tested negative for COVID-19 by RT-PCR, and the patients with lens-induced glaucoma were treated medically with anti-glaucoma medications before taking them up for surgery. Data collected during the study period was compared with the previous corresponding year's data obtained from institutional records to calculate the increase in the proportion of hypermature cataracts. In our study, we observed that it included a range of age groups extending from 40 to more than 70 years of age, and the population and most of the population ranged from 61 to 70 years age group, and female preponderance was seen in our study, which accounted to nearly 60%. And most of the population was hailing from rural areas, which it's almost approximating to 70%. Patients presented with Morganian cataract were about 76 cases. Those presenting with major sclerotic were 151, and patients presenting with phacolytic glaucoma were 105, and 66 patients also presented with subluxation. In the corresponding pre-COVID year, about 5,000 cataract cases were operated in the Department of Ophthalmology at a tertiary center on a yearly basis, of which 384 cases presented with hypermature.
It's time up.
Yes, ma'am, I'll speed up, ma'am. But since a year from the commencement of COVID-19 pandemic, only 2,500 cataract cases were operated, as the elective surgery was halted for several months during the second wave of COVID-19, out of which 398 patients presented with hypermaturity. As we can see, the proportion of hypermature cataract during the pre-COVID era was about 7.68%. But during the pandemic era, it is about 15.92. Though the number of cases operated were almost half, that is 2,500, there was a certain increase in the proportion. There was a twofold increase in the number of hypermature cataract cases seen. When patients were questioned based on the standard questionnaire, these are the following reasons given by them. Restricted motility and lack of public transport facility being the most answered question. Fear of getting infected with COVID during the hospital visits, lack of support from the family members or no accompanying attenders to attend the hospital. Patient himself or his attenders were tested positive or were with severe COVID infection. Fear of being tested positive during the routine pre-op investigation, which mandates isolation. Lack of elective cataract surgery during the lockdown period. Reduction or cancellation of government-held camps, especially in the rural areas during the COVID-19 pandemic. With the ease of restriction, preference of getting systemic comorbidity treated over the eye problems, and few of the patient didn't agree with any of the reasons. As we can see that restricted motility, that is lack of public transport facility during the lockdown, and lack of elective cataract surgery were the main reasons given by the patients for the delayed presentation. Conclusion. The COVID-19 pandemic halted non-emergency services across India. Elective cataract surgery postponed during the pandemic invariably led to longer wait and possible COVID-related anxiety among the patients. Thus, immature cataract attaining hypermaturity state and its complication. Patients' apprehension about having cataract surgery during the easing of COVID-19 lockdown should not be ignored and thus needs adequate counseling. In spite of wide coverage and program, hypermature cataracts are commonly found in the rural and suburban populations of India. COVID pandemic has definitely resulted in a setback of these programs. An effort was made by the study to herald about this crisis. References. Thank you.
Yes, Dr. Soumya, can you hear me?
Yes, ma'am.
Yeah.
Yes, ma'am, I can hear, ma'am.
Pre-COVID, you had 384 patients with the hypermature cataract, and during COVID
Yes,
time,
ma'am.
398. So how the difference
Yes.
is not much, isn't it?
Yes, ma'am, but the proportion of total number of
Proportion is
patients.
because your denominator is smaller.
Yes, ma'am. Yes, ma'am.
So that cannot extrapolate that the hypermature cataracts have increased.
Okay, ma'am.
So because the denominator
Ma'am.
is small, your percentage is larger.
Okay, ma'am. Okay. Ma'am, but like as we saw, the number of patients presenting with the complications like subluxation and phacolytic glaucoma, they were more compared to previous year, ma'am.
No. Then you should have another sublist, hypermature cataract with complications.
Okay, ma'am.
So you just said hypermature only. You didn't show
okay,
that how many had extra other complications due to hypermaturity.
Yes, ma'am.
Do you have a slide?
Yes, ma'am. Is it visible, ma'am?
Yeah. So pre-COVID?
Pre-COVID, I don't have the calculation. I just used it for.
Unless you have that.
Okay, ma'am.
Yeah. And all these patients were from a camp or from the hospital?
All these were from hospital, ma'am. Patients attending regular OPD. Yes, ma'am.
Oh, got it. Yeah, that's all from my side.
Dr. Soumya, in your exclusion criteria, you said the second criteria, what was it? It is the other eye being good, right?
Yes, ma'am. Yes, ma'am. Yes, ma'am.
Were bilateral? Were all your cases bilateral?
Not necessary, ma'am. Few of them were, few of the patients had lesser grade of cataract, ma'am. So they were having better vision in other eye. So they didn't come. That's why, ma'am, even if they don't have a good vision, what is the reason for delay? That was the main aim of study, ma'am. Hello?
Yeah, okay, but I think you have said presence of good vision in the other eye.
Yes, ma'am. Good vision either because of lesser grade of cataract or either because of zodophakia.
Good vision.
Excluded.
But then you should specify vision more than what?
Okay, ma'am. Okay.
See, usually patients who have good vision in the other eye are the one who come with these complications because they ignore this eye.
Yes, ma'am. Yes,
so
ma'am.
I don't think they should be excluded.
Okay, ma'am. Like as I wanted to tell that during the COVID era, though they have a visual problem, they were not able to approach hospital or any health facility because of this pandemic. So I focused more on those causes, ma'am, rather than the other causes which can.
No. I mean, your patients who had phacolytic glaucoma, what was the vision in the other eye?
They had good vision, ma'am. Few of them had good vision. Few of them had lesser grade of cataract as well.
Correct.
But
again comes under your exclusion criteria.
Yes, ma'am.
So that cannot be.
Okay, ma'am. Okay.
You cannot exclude them.
Okay, ma'am. I'll modify it.
Yeah, that's all from my side.
Yeah, that's all from my side also.
Okay. Thank you, ma'am.
Okay, so now Dr. Divyashree, will you be able to present?
Yes, ma'am, I'm sorting out the issue. I'll be back, ma'am.
You're ready?
No, ma'am, I'm taking the technical support. I'm in the support department. I'll just be back, ma'am.
How many minutes?
Just 2 to 3 minutes, ma'am. I'll be back.
Yeah, because the other people are waiting for their session to start.
Shall I just try once, ma'am?
Yeah.
This one. Is it visible now, ma'am?
Your computer screen is visible. In that PPT we can make out, yes. Put it in the slideshow, yes. Yeah, we can see now.
Is it fine, ma'am?
Yes, yes. Yeah. Start.
Is it in the
And starts
slideshow
now.
mode, ma'am? Okay. Sorry for the inconvenience caused, ma'am. Yeah. My study is about the effectiveness of the opportunistic screening for diabetic retinopathy. Diabetes is a chronic metabolic disorder leading to microvascular and microvascular complications. And diabetic retinopathy is the most frequently occurring microvascular complication in the eye, and its prevalence is around 21%. Effective strategy to combat blindness due to diabetic retinopathy lies on screening and early recognition of disease. And various screening strategies are developed for early recognition of the disease, like mass screening, community screening, active and passive screening at hospitals. And opportunistic screening is community screening models at recognizing diabetic eye disease among the subject attending the cataract camps. Our aims and objectives are: the aim is to know the study effectiveness of opportunistic screening for diabetic retinopathy in cataract camps. And primary objective is to measure the detection rate of the diabetic retinopathy, including sight-threatening diabetic retinopathy. And secondary objective is to measure the treatment or follow-up rate in patients with sight-threatening diabetic retinopathy, and to document the change in the grading of diabetic retinopathy severity before and after cataract removal. And our study was made between June 2019 up to December 2020, which included 53 camps conducted in all of this duration, was tabulated accordingly. And camp population was selected. In that, the patients without diabetes were categorized and sent for cataract assessment and followed up and treated for cataract. And the patients with diabetic who were already known diabetic were further done detailed fundus examination, dilated fundus examination. And the patients with newly detected diabetes,
your voice is Dr. Divya, your voice is breaking.
I think being from Bangalore, we shouldn't have a net problem.
Hello.
We cannot hear you, Dr. Divya.
Can you hear?
Yeah, now we can. In between, there was disturbance in your.
Is it fine?
No, it's not.
Okay.
Now you continue. Hello.
So we cannot give you extra time. This is a third attempt.
Yeah.
Sorry if you are not able to connect. I think, shall we conclude the session?
I think so, ma'am. It's already time.
Yes.
Yeah.
If anybody is from KOS, please note that this is a third attempt she's been given, but still could not succeed, and she has lost connection.
I think we'll end this session.
Okay, so we are done with the session then.
Yeah. Thank you.
Thank you all.